There is one blood pressure myth that causes a huge amount of confusion for older adults, and it sounds so reasonable that almost nobody questions it. The myth is this: once you get older, your blood pressure should still be exactly 120/80, and if it is not, something is automatically wrong. That sounds clean, simple, and reassuring. But in real life, it is not that simple, because in older adults, the right blood pressure is often less about chasing a perfect-looking number and much more about finding the safest, healthiest range for the actual person sitting in front of you. And that matters a lot, because the wrong belief can push people in two different bad directions. One direction is undertreating blood pressure because they think, well, I'm older now, a higher pressure must be normal for my age. The other direction is overtreating blood pressure because they are trying to force every reading down to a textbook number, even when that person is getting dizzy, tired, foggy, or unsteady. And both of those mistakes can be dangerous. One can leave you exposed to strokes and heart attacks, and the other can leave you exposed to falls, fainting, medication side effects, and loss of independence. So in this video, I want to give you a practical way to think about blood pressure if you are a senior or if you care for one, because the truth is much more useful than the myth. We're going to talk about where the 120/80 idea came from, why it doesn't work as a one-size-fits-all target in older adults, when lower blood pressure is genuinely beneficial, when lower can become too low, and how to think about your own target in a much smarter way. And by the end, I want you to feel like you can walk into your next doctor's visit and ask much better questions. Before we dive in, please subscribe so you never miss science-based videos to help you live longer and feel better. And if you're new here, I'm Dr. Jessica Morgan. On this channel, I focus on the science and the real-world decisions that shape healthy aging. One quick reminder before we go further: this video is educational, not personal medical advice, so please use it as a conversation starter with your own clinician, especially if you take blood pressure medication already. All right, let's get into it. The first thing we need to clear up is what 120/80 actually means. A lot of people treat it like a universal commandment, almost like every human body should be pinned to that exact number all the time. But 120/80 is better understood as a reference point. It is a normal blood pressure category for adults. It is not automatically the ideal medication target for every older person, every day, under every circumstance. And those are very different ideas. A healthy category is not the same thing as a treatment destination. That distinction matters even more in seniors because blood pressure is not just a number on paper. It is a pressure system that has to perfuse your brain, your kidneys, your heart, and the rest of your body while you are sitting, standing, walking, eating, sleeping, taking medications, and dealing with all the changes that come with age. So when somebody says my pressure has to be 120/80 or else, they are flattening a very complicated physiologic reality into one slogan. And the body, especially the older body, really does not behave like a slogan. Now, does that mean 120/80 is bad? No, not at all. For some older adults, especially healthy and active ones, blood pressure in that neighborhood may be completely appropriate and even beneficial. The myth is not that 120/80 is always wrong. The myth is that it is always the right target for every senior. That is the mistake. Because once you understand the evidence, what you see is that lower can be very helpful in the right person, but pushing too hard in the wrong person can absolutely backfire. And I think this is where a lot of people get tripped up because they hear two messages at the same time. On one hand, they hear that lower blood pressure reduces the risk of stroke, heart attack, heart failure, kidney problems, and maybe even cognitive decline. That is true. On the other hand, they hear that older adults are more vulnerable to dizziness, falls, medication side effects, and low diastolic pressure. That is also true. So the real question is not whether blood pressure matters. Of course it matters. The real question is lower for whom, how fast, with what symptoms, and at what cost. To answer that, we have to talk about aging itself. Because as we get older, blood vessels usually become stiffer. That stiffness changes the blood pressure pattern in a very predictable way. The top number, which is the systolic pressure, often rises. The bottom number, which is the diastolic pressure, may stay the same or even drift downward. So you can end up with a pattern like 152/68 or 146/62, and that pattern is incredibly common in older adults. It is called isolated systolic hypertension, and it is one of the main reasons this conversation gets more nuanced with age. If you're younger, you might imagine blood pressure like a hose with flexible walls, but with aging, the arteries are less elastic, more like a hose that has stiffened over time. That means the pressure wave behaves differently. The heart has to push against a stiffer system so the top number can climb. Meanwhile, the bottom number may not rise with it, and sometimes it falls. So when someone says, I just want both numbers to be 120/80, what they may not realize is that the biology of aging often makes that far more complicated than it sounds. And here is where the danger comes in, because if all you focus on is forcing the top number down, you can sometimes drive the bottom number too low in the process. That matters because your heart muscle gets its own blood supply during diastole, which is when the heart relaxes between beats. So if the diastolic pressure gets too low, especially in someone with stiff arteries or coronary disease, that can create problems. In other words, a beautiful looking systolic number can hide a diastolic number that is no longer serving the person well. So already you can see why one fixed target is too simplistic. An active 68-year-old who walks every day, has good kidney function, takes very few medications, and feels great at lower pressures is not the same as an 84-year-old with neuropathy, kidney disease, orthostatic dizziness, and a history of falling in the bathroom at night. They may both be called seniors, but medically those are completely different situations. And when the situations are different, the target often has to be different too. This is also why blood pressure advice sounds contradictory sometimes, because different expert groups have weighed the same evidence in slightly different ways. Some have favored a more aggressive approach, saying that getting under 130/80 gives better cardiovascular protection for many adults, including many older adults. Others have been more cautious, emphasizing that lower targets can increase side effects and may not be worth it in every patient. So when people say, why are doctors giving different answers? It is often because the real evidence does not support one universal answer. A big part of that conversation comes from one major study, and it changed the field. In that study, thousands of adults at elevated cardiovascular risk were assigned to one of two strategies. One strategy aimed for a systolic pressure under 120. The other aimed for under 140. And the lower target group had fewer major cardiovascular events and a lower risk of death. That was a very big deal, and it helped push blood pressure treatment in a more intensive direction for many patients. But this is where the fine print matters, because the headlines from a trial and the real-world interpretation are not always the same thing. The participants in that study were not every kind of older adult. People with diabetes were excluded. People with prior stroke were excluded. Frailer institutionalized patients were not really the core population. So when someone takes the results of that study and turns it into everybody older should be at 120 no matter what, that is going far beyond what the study actually proved. There is another subtle issue, and it's one that almost nobody outside medicine hears about. The blood pressure in that trial was measured in a very specific way, using automated office measurements under conditions that often read lower than the hurried, typical clinic reading people get in everyday practice. So a target that sounds like under 120 on paper may not translate neatly into the exact same number in a regular real-world office setting. That does not mean the study was wrong. It means applying the result requires judgment. Now, importantly, that same body of evidence also suggests something encouraging. Healthy older adults can benefit from lower blood pressure goals, and age alone is not a reason to give up on treatment. That is such an important point. There used to be this lingering belief that higher pressure was somehow necessary or acceptable just because a person was older. But untreated high systolic blood pressure remains a major driver of stroke, heart failure, and vascular problems in older age. So you're older, so let it run high is not a smart strategy either. And then we have data in people over 80, which adds another layer. Those studies show that treating high blood pressure in very old adults can absolutely reduce important outcomes like heart failure and overall mortality. So the message from that evidence is not, don't treat blood pressure after 80. The message is, treat it thoughtfully. In very old adults, the goal is not to ignore hypertension. The goal is to reduce risk without tipping the person into weakness, dizziness, kidney injury, or a fall that changes the course of their life. That right there is the heart of the issue. The blood pressure myth for seniors is not just wrong because the number is oversimplified. It's wrong because it treats blood pressure as if the only thing that matters is the chart. But the chart is not the patient. The patient is the patient. And when I think about blood pressure in an older adult, I'm not just asking what is the number, I'm asking how is this person functioning? What are they feeling? What medications are they on? What happens when they stand up? What happens to their kidneys? What happens to their balance? Let me make this more concrete because I think examples help. Imagine a 67-year-old who is active, independent, sharp, still exercising, and not taking many medications. If that person has a systolic pressure running in the 140S or 150S, it often makes sense to work that down, sometimes quite assertively, because they may gain years of cardiovascular protection from doing so. If they tolerate a lower pressure well with no dizziness, no kidney issues, and no low diastolic concerns, then a lower target may be very reasonable. Now imagine a different person, an 81-year-old who is already taking 7 medications, has some chronic kidney disease, feels lightheaded when standing, and has fallen twice in the last year. If that person's pressure is being chased aggressively downward only to satisfy a theoretical ideal, that can become dangerous very quickly. In that situation, a perfect-looking number might be buying you a worse reality. A fracture, a brain bleed from a fall, an emergency visit for dehydration, or a major loss of confidence in walking can be life-changing in older age. And this is why I want you to hear this next point very clearly, because it is one of the most important ideas in the entire video. The best blood pressure for a senior is not the lowest blood pressure they can possibly achieve. It is the lowest pressure that gives meaningful protection without causing harm. That is a very different standard. We are not trying to win a math contest. We are trying to protect the brain, the heart, the kidneys, and the person's ability to live their life. Sometimes people assume that if low blood pressure is good, then even lower must be better. But biology usually doesn't work like that. There is often a sweet spot. Too high increases risk, but too low can also increase risk, especially in more vulnerable older adults. If someone is getting weak, wobbly, washed out, confused, or faint after medication changes, those are not little side notes. Those are clinically meaningful signals. The body may be telling you that the treatment strategy looks good on paper, but is not working well in real life. One of the most underappreciated problems here is orthostatic change, which basically means what happens to blood pressure when you move from lying or sitting to standing. An older person may have a blood pressure that looks acceptable while seated in the clinic, but then the pressure drops substantially when they stand. That is when you hear, I feel fine sitting down, but when I get up, I'm suddenly unsteady, or I get this weird wave of lightheadedness on the way to the bathroom. Those symptoms matter just as much as the sitting number. And the risk is not just discomfort, because the consequences can be huge. A fall in an older adult is not a minor inconvenience. A hip fracture can set off a cascade of surgery, immobility, muscle loss, rehab, sleep problems, depression, and loss of independence. A head injury can be devastating, especially if the person is also taking a blood thinner. So when somebody says, just lower it more, without asking how the person feels when they stand up, walk across the room, or wake up at night, they may be missing the outcome that matters most. The kidney piece matters too, because the kidneys are very sensitive to changes in blood flow and medication effects. In some people, especially those who are older and already have chronic kidney disease, more aggressive blood pressure treatment can push kidney numbers in the wrong direction. That doesn't mean kidney changes always require backing off immediately, but it does mean monitoring has to be deliberate. If a blood pressure plan is intensified, there should often be follow-up for symptoms, labs, and overall tolerance, rather than just assuming all is well. Then there is the medication burden, which is a huge issue in seniors. It is one thing to lower blood pressure with one well-tolerated medication and good lifestyle habits. It is another thing entirely to stack multiple drugs in a person who is already taking medicines for pain, sleep, mood, bladder issues, diabetes, reflux, cholesterol, and maybe something else on top of that. Every additional pill introduces the possibility of side effects, interactions, confusion about timing, or missed doses that create even more instability. This is why the phrase treat the patient, not the number, is so important, even though it can sound a little cliche. In blood pressure care for seniors, it is actually profound. If the number improves but the patient is more fatigued, more foggy, less mobile, less steady, and less confident leaving the house, then we have to ask whether we truly improved their health. Numbers matter, yes, but numbers are supposed to serve function, not replace it. Now, I also want to push back on the opposite myth because some people hear all of this nuance and conclude, okay, so blood pressure goals don't matter after 70. That is not true either. High blood pressure remains a major cause of preventable stroke and heart disease in older adults. Letting a systolic pressure sit chronically at 160, 180 because someone is older is not a neutral decision. That is still dangerous. So this is not a video telling you to stop caring about blood pressure. It is a video telling you to care about it intelligently. The smartest way to think about it is to separate three different ideas that people often mix together. First, that there is the category of normal blood pressure. Second, there is the treatment threshold, meaning when a clinician decides it is time to intervene more actively. Third, there is the individualized target, meaning where that specific person should aim given their symptoms, risks, and overall health. When those three ideas get collapsed into one phrase like 120/80, confusion is almost guaranteed. Let's talk more about the bottom number for a minute because it gets ignored way too often. In older adults with stiff arteries, the diastolic pressure can drift low even while the systolic stays high. So you might see a reading like 148/58. People look at the 148 and immediately want to lower it, which may be reasonable, but the 58 should make you pause. Not panic, but pause. Because if you lower the top number without paying attention to the bottom number, you can create a situation where the arteries are technically less pressurized, but the patient feels worse. Related to that is something called pulse pressure, which is simply the difference between the top and bottom number. If the reading is 150/70, the pulse pressure is 80. The wider that gap gets, the more it often reflects arterial stiffness. That wide pulse pressure can be a clue that the person's vascular system is aging in a way that makes blood pressure management trickier. Again, that doesn't mean do nothing. It means we need to be thoughtful and not pretend that 150/70 behaves the same way as 150/90 in a younger person. Another reason 120/80 becomes a misleading obsession is measurement itself. Blood pressure is incredibly sensitive to how it is taken. If someone rushes into the clinic, sits down for 15 seconds, crosses their legs, keeps their coat on, talks through the measurement, and then gets a reading of 154/82, that number may not represent their true resting blood pressure at all. On the other hand, if somebody checks it at home correctly after sitting quietly, using the right cuff at the same time each day, the picture can look very different. And home monitoring is especially useful in seniors because it helps you see patterns rather than one-off snapshots. One reading is a moment, a blood pressure log is a story. It tells you what happens in the morning, what happens after medication, whether the pressure crashes after lunch, whether it spikes when the person is anxious, and whether there is a big difference between seated and standing readings. That kind of information is much more actionable than one isolated number from a stressful clinic visit. If you monitor at home, the method matters. Use an automatic upper arm cuff, not a wrist device if you can help it. Sit quietly for several minutes first. Don't smoke, exercise, or take caffeine right beforehand. Keep your feet flat, your back supported, and your arm at heart level. Don't talk during the reading. And take more than one reading instead of latching on to the first one emotionally. Those little details sound boring, but they are often the difference between useful data and misleading data. One very practical thing I often wish more older adults would do is record symptoms next to the numbers. Write down the blood pressure, yes, but also write down felt great, or dizzy on standing, or wobbly after breakfast, or headache, or took meds late. That is gold in a clinic visit because a blood pressure of 128/72 means one thing if the person feels strong and clear-headed, and something very different if they nearly blacked out getting up from the chair. So if 120/80 is not the universal answer, what is? Well, the most honest answer is that there isn't one single number for every senior, but that doesn't mean we have no framework. We do. For many healthier older adults, especially those who are active, independent, cognitively intact, and tolerating treatment well, getting the systolic pressure below 130 is often a reasonable and beneficial goal. In some of those people, going lower can make sense if it is done carefully and the person feels well. And once someone is into their 80s and beyond, the pace of treatment becomes incredibly important. Even when lower blood pressure is the destination, getting there too abruptly can be a problem. This is why careful clinicians often move in smaller steps, reassess symptoms frequently, and monitor labs when medications are adjusted. The older body can absolutely benefit from good blood pressure control, but it often appreciates a gentler runway. Fast, aggressive, and theoretically perfect is not always better than slow, steady, and well tolerated. I think one helpful way to simplify this is to ask 4 questions. First, how high is the blood pressure really, based on repeated accurate readings, not just one dramatic reading? Second, how robust is the person physically and cognitively? Third, what symptoms show up when we lower the pressure? And fourth, what trade-offs are we making in medications, kidney function, balance, and quality of life? Those 4 questions will usually get you much closer to the right answer than repeating 120/80 ever will. Let's walk through 3 quick examples because I think they make the idea stick. Example 1, a 72-year-old who still hikes, manages all their own affairs, has good kidney function, and consistently runs 148 to 152 systolic at home. This person may very well benefit from getting lower, potentially below 130 systolic if they tolerate it, because the upside in stroke and cardiovascular prevention is meaningful and the downside may be relatively low. Example 2 is an 85-year-old who has mild cognitive impairment, gets dizzy on standing, takes multiple medications, and has a blood pressure around 138/62 while seated, but much lower after standing. For that person, chasing 120/80 could be a terrible idea. The seated number may already be acceptable in context, and the standing number may actually be the more important one because that is the number linked to symptoms and falls. Same age category? Yes. Same target? Probably not. Example 3 is the person with a high top number and a low bottom number like 156/58. This is where nuance becomes absolutely essential. They may need treatment because the systolic is too high, but the treatment has to be selected and adjusted carefully so the diastolic does not crash further and leave them feeling worse. This is one of those cases where blood pressure management becomes less like following a rule and more like balancing a system. Another thing I want older adults to hear very clearly is that symptoms matter even when the blood pressure looks good. Too many people assume that if the reading is technically in range, then the treatment must be right. But if you start a medication or increase a dose and suddenly you are more tired, less steady, less sharp, more crampy, or more hesitant to leave the house, that deserves attention. Sometimes the problem is not aging. Sometimes the problem is overtreatment being mistaken for aging. Lifestyle matters here too, and I never want these conversations to sound like blood pressure is only about prescriptions. For many older adults, reducing excess sodium, staying physically active, improving sleep, managing weight, and limiting heavy alcohol intake can make a real difference. Even modest improvements can reduce how much medication is needed, and that can matter a lot if someone is very sensitive to side effects. Sometimes the best blood pressure strategy is not simply more medicine. Sometimes it is a smarter overall system. So the blood pressure myth for seniors is not just that 120/80 is wrong. It is that one number alone can replace clinical thinking. It can't. The best blood pressure target in older adulthood comes from balancing evidence, symptoms, function, risk, and tolerance. That takes a little more effort than repeating a slogan, but it leads to better care, and better care is the whole point. If your current reading is high, don't ignore it. If your current treatment is making you feel lousy, don't ignore that either. Both matter. The answer is not to be casual about blood pressure, and it is not to chase a perfect looking number at all costs. The answer is to work with your doctor to find the range that protects you without destabilizing you. And honestly, that is the most empowering part of this whole conversation. You do not need to memorize one magical number. You need to understand the framework. Accurate readings, repeated patterns, symptoms, standing blood pressure, diastolic pressure, medication burden, kidney function, fall risk. When you understand those pieces, you stop being trapped by the myth and you start making smarter decisions. I hope this helped clear up a topic that confuses a lot of people because this one really matters. If you found this useful, share it with a parent, a spouse, or a friend who is always being told that blood pressure should be one exact number no matter what. And as always, talk through any medication changes with your own clinician before making them. Stay healthy, and I'll see you in the next one.